Good evening, everybody, and welcome to our monthly episode of the University of Miami Cerebrovascular and Skull-Based Surgery Symposium. I remind you, it will be every third Thursday of the month at 5 p.m. Eastern Time. It'll go until about 7 or 7:30, depending on how much excitement is going on in the session. This is session 33, and on April 15, 2021. I will introduce our wonderful panelists at the end of my quick introduction, but here, of course, is a flyer, and that's the order in which they are going to present today. Those of you interested in our sessions for this symposium for the rest of the year, here they are. I'll show this slide again a little later if you're interested in taking a screenshot or saving it. We've just put it out yesterday in our social media, so you all know what's coming, and it's of course an alternating series of skull base and cerebrovascular. You can see we have spectacular people coming on board to keep this virtual education move going forward. For how long? I don't know. We'll see what happens with COVID, of course. Nick Khan will be joining us, my current fellow and the future superstar, going back to University of Tennessee in Memphis. He will join us on every one of these sessions to present one case from our institution to the panelists, and today is no exception. I'm Jacques Morcos, professor and co-chair of the department and director of cerebrovascular and skull base, and of course my co-directors Carolina Benjamin, who runs our Keynes lab, the cadaveric dissection lab, and Carolina specializes in brain tumor and skull-based surgery. Here, Mike Ivan, director of research at the Brain Tumor Initiative, BTI, specializes in brain tumor, skull base, and epilepsy surgery, and Bobby Stark, co-director of endovascular. Those of you interested in pediatric neurosurgery, on one Monday a month, my colleagues and partners, Toba Niazi, Heather McRae, John Rageb, Shelley Wang, also have a fantastic series of pediatric neurosurgery presentations. Please join that. Mike Ivan, my colleague, and the rest of us runs also a very successful Miami Global Brain Tumor Symposium on the first Wednesday of each month. May 5th, the next month, he has a very nice combo presentation with surgeon's log from North American Skull-Based Society and our neurootology colleague Simon Angeli here, and his fellow Scott Brown, along with Lois Borba from Brazil on glomus jugulare tumors. So please don't miss that. Regarding this symposium next month, May 20th, we have Danny Prevedello, Mustafa Bashkaya, Amir Dedashti, and Sebastian Frolik. Of course, it'll be skull-based topics, and you can read these exciting titles of the lectures for yourselves in blue. Thank you to the team that makes these educational events possible. Here they are all, and particularly Ignacio, who runs actually this webinar here. This is a link. Those of you who want to watch previously recorded sessions, we have a bunch now on our YouTube channel, on our University of Miami website. This is a link in the yellow box, and you can reach out to any of those emails. You can reach out to me for questions, my email, or on my Twitter account, or there is a departmental Instagram and departmental Twitter account. Unlike last year, this format, I decided to do it a bit differently. As you can see, 4 international known speakers every month on a CV or skull-based topic, 20 to 25 minutes each. Then Dr. Khan will present one case for discussion by the panel. And then, of course, the most important thing is listening to you, the audience. So please submit your questions in the Q&A box. Throughout the lectures, we will the co-directors and myself will look out for, try to answer, to have the panelists answer all of your questions. So now, my great pleasure is to introduce the panelists for today. Paul Camarata has been my good friend from the early 90s. We did residency together, University of Minnesota. Of course, Paul is chair at University in Kansas City. Paul is a spectacular master skull base and cerebrovascular surgeon, and I'm delighted he chose what might look like a basic talk, but is not basic at all. The mastery of splitting the sylvian fissure and how to approach vascular and paracellular lesions. So I'm looking forward myself to listening to what Paul has to say. Second speaker will be David Langer, again, my friend for many, many moons, certainly more than 20 years. David is probably better known to all of you. Well, if there were a lay audience today, we would say better known to all of you as the star, one of the two stars, at least two neurosurgical stars from Lenox Hill Hospital, very popular Netflix series. And if you want to catch the humanity of this man, just watch that series. This is exactly how he is with his patients, with his friends, and of course, he's a master cerebrovascular surgeon and endovascular as well. And now innovation doesn't scare him. And I remember him bringing to the US kind of the ELANA project of bypasses, and he's always thinking outside the box. And of course, now today he's going to talk about exoscope surgery for vascular neurosurgery, and he believes that future is now. So we're looking forward to that. Giuseppe Lenzino, I remember him when he was applying for fellowship and actually looking for a job at the beginning, and you could clearly see a star in the making from those years ago. I think Giuseppe is clearly one of the most academic and probably published neurosurgeons in the world. He is one of the most thoughtful people, and of course, extremely busy vascular, both open and endovascular. And his talks are always a gem because he puts a lot of thoughts into them. And today he's going to show us and talk to us about this very complex and vexing problem of dural AV fistulae that are, of course, usually amenable to both open but predominantly endovascular. And again, looking forward to that. Last but not least, my compatriot, Pascal Jabour at Jefferson. Pascal is a dynamo, is an energetic hurricane, and of course he's my compatriot from Lebanon. And Pascal is just an incredible force of nature in vascular, both endo and open. Again, an innovator who's not afraid to push the limits of state-of-the-art things. He's done it in many fields, particularly within endovascular. And today is no exception. And unfortunately, he's not going to talk to us about his real expertise, which is wine aficionado, but he can give you lectures about that and teach us a lot about this. He's going to talk to us about the exciting world of neuroendovascular robotics, again, a new frontier. So again, if you wanted to capture this slide for the future planning for the rest of the year, here it is. And I've spoken enough, and I now will stop sharing, and I invite Paul Camarata to share his screen, unmute his microphone. And Paul, the floor is yours. Thank you very much.
Can you hear me, Jacques?
Very well.
All right. And I should be on my first slide right now. Does that look good?
Looks great, Paul.
Fantastic. Thank you so much, Jacques, for inviting me to be a part of this. Really is a wonderful educational opportunity that you have really been at the forefront of over this pandemic and last year, and I appreciate being a part of it. At the end of this talk, the title of which is Splitting the Sylvian Fissure, a Necessary Skill to Approach Vascular and Paracellular Lesions. At the end of the talk, I hope that you will understand the reason that I think it's imperative that you learn the technique, that you use it on as many supratentorial lesions around the skull base as you can. And by the end of this talk, I think you'll appreciate the forest analogy here from these aspens you see in New Mexico. I'll give you a brief outline in a moment of the approach. We'll talk about the anatomy, but I really wanted to impress upon you the wonderful view, the wondrous views and amazing vistas that you see when you master the technique of completely splitting the Sylvian fissure. And I have to tell you, it's something I did not learn as a resident. I hope that my residents now are learning this, but when I was a resident, we were taught to put a couple of retractors on each lobe, frontal and temporal lobe, like opening a book was the word used. And then you would gently split the Sylvian fissure. So I learned this since my residency by watching people like Jacques, like Giuseppe, like David, by reviewing videos, by traveling and seeing the way other people did this. So there are also, I want to impress on you that there are obvious lesions that this will be used in, you know, the middle cerebral aneurysm, the insular tumor, but there's a lot of not so obvious lesions that you can use this on, and that's what I'll talk about. So again, some brief historical notes, anatomy, the principles of the approach, the technique, and give you some examples. Now, a little history, because I know Giuseppe and Jacques are interested in this. Galen first described the cerebral cisterns about the year 200 AD. And if your little icon or picture up here is not covered by the Zoom panel as mine is, you'll see that Galen has a monkey next to him because he was experimenting on primates. He was a Greek who was in Rome at the time and took care of the gladiators, really. So he described terrible brain injuries. Veroli was the first to describe the arachnoid membrane, and Vesalius, the famous professor of anatomy at, I believe, Padova, actually named the arachnoid membrane in 1670. In Vesalius's own book, De Humani Corporis Fabrica, he had this diagram, and if you look at the diagram here, he really just made the gyri random. You don't see a lateral fissure here. He said the gyri or convolutions of the brain are found with the same frequency over the whole surface of the brain. I think they could be perfectly compared to the clouds drawn by a school child. We now know that is obviously not the case. Well, who did discover the Sylvian fissure or the lateral sulcus? Well, leave it to the Italians who discovered blue jeans, the piano, espresso, newspapers, wine, some will say. Who discovered the Sylvian fissure? Well, the Italians wrote an article here 13 years ago. It was first identified by Fabrizio d'Acquapendente, Fabrici of the Hanging Waters, or the city Acquapendente. And it turns out he was a chairman of anatomy and surgery at Padova, also like Vesalius, following him. He discovered in color plates, so it was discovered in colored plates that he had painted. He wanted to create 300 plates of human anatomy and actually had created a number of these exquisitely painted. And they were discovered in San Marco Library in Venice. And actually, they were never published, so he doesn't really get the credit, Giuseppe, of discovering the fissure. But you see it here in one of these exquisitely painted diagrams that is currently in the San Marco Venetian Library. But who is the fissure named after? Well, it's Franciscus de la Bois, or Dubois, which Jacques would tell you means of the woods. And that's where we get his name. You've heard of Sylvan Woods. Sylvius is the Latinization of Dubois. So it's Franciscus Sylvius. He was born in Hanover, Germany, the site of where some may say the most proficient neurosurgeon in the world currently still practices, Majid Sami, who has split the fissure hundreds and hundreds of times, undoubtedly. So Dubois, or Sylvius, moved to Amsterdam. He developed a lucrative medical practice, and it was drawn and described for the first time in the book by Bartolini. And you see the fissure right here. You see the depth of the fissure and the insula in this first diagram from the 1500s. In there, it is published FS, that's Franciscus Sylvius. If you examine the indentations represented in figure 5, which you just saw, you'll notice they are very deep. The brain is divided from one side to the other by the anafractuosa fissura, which starts in the front part near the ocular roots and moves backwards, etc., dividing the upper part of the brain from the lower. And this was Sylvius in 1663. However, I will tell you it probably was an Italian, but not Sylvius. who was actually the first to describe this. Now, Sylvius, there's a little backstory that he discovered gin in Holland by using the juniper plants. This is patently false because gin existed about 200 years before Sylvius, but it's a cool story and great cocktail conversation. But what about this? This, in the Judeo-Christian tradition, is the Sistine Chapel ceiling painted by Michelangelo Buonarroti. And this, again, in Judeo-Christian tradition, God creates Adam. And you will notice, and others have noticed, that looking at God and the cherubs and figures around him and the veil, that he looks like a sagittal section of the human brain, complete with the medulla oblongata, the pituitary stalk, and indeed the cincture, the little belt that he wears around his waist, which is coincident with the Sylvian fissure. And this is probably not God creating Adam, as it's been called, the creation of Adam. Adam's eyes are open, the fingers are not yet touching, but rather God giving reason to Adam. So perhaps discovered, or at least placed in art 150 years earlier by another Italian, Michelangelo. But we know it mostly now as from in modern neurosurgical terms because of Professor Yazergil. And in fact, one of his students has actually published an article, Professor Aden, called The Yazergil Highway in Neurosurgery. So the Sylvian fissure was popularized in the approach through the Sylvian fissure, the Transylvian approach, by Professor Yazergil. And I would encourage you, I had a copy of his book here, but I don't have it at the moment, just to show you any young person who is starting out and really wants to get a great example of what the cisterns look like, and to describe microsurgical dissection techniques, approaches to aneurysms, et cetera, to get your hands on a copy of Professor Yazergil's book. Yazergil noted that all fissures are not alike. Some are very patulous like this, where you can look through the arachnoid and actually see the arteries, and others are stuck together like this, where the arteries are buried beneath the frontal and temporal lobes, where the frontal lobe indents the temporal lobe slightly, or the temporal lobe indents the frontal lobe. Yazergil said, in principle, it would be ideal if the brain could be left completely undisturbed while the dissection and clipping of an aneurysm was carried out. The craniotomy must take advantage of those natural planes and spaces which nature has provided to expose the base of the brain without significant brain retraction. And that is the real reason that you should all learn to split the Sylvian fissure. One of his disciples early on, an American, John Fox, who was in the United States for many years, and this book is still available in electronic form, The Atlas of Neurosurgical Anatomy, with exquisite pictures of the terrinal approach and the Transylvian approach. Fox says, as we have gained more experience, and I think all of us on the call would probably second this, we have opened the Sylvian fissure more and more. So Fox's reasons, why do we do it? Small vessels are not compressed by the arachnoidal bands, less resistance, and hence less brain retractor pressure to the frontal lobe and the temporal lobe. Traction on one lobe does not pull or injure the other. Fewer bridging veins need to be sacrificed. Back in the day when he published this book some 40 years ago, was perhaps a little unusual to preserve the olfactory nerve in some of these cases, and minimal traction on the perforating vessels and aneurysm. Why avoid traction? Here's an article I found from Manny DeHavny and Peter Giannetta's lab from 1975. This was in the Surgical Forum, which some of you may get. It's published with the Clinical Congress, the American College of Surgeons, every year. And you see the damage caused by only 40 torr of brain retraction for an hour. This is in a canine brain. And they placed strain gauges on retractors and showed the amount of pressure, upwards of 40 and 50 torr, that was exerted on the underlying brain by retractors. And that just doesn't happen when you completely release the Sylvian fissure. So why split the fissure? Some would say because it's there. Because there is less brain retraction, more brain relaxation, and better exposure. Why not split the fissure? Many would say, you don't need to do it in every case. And it is time consuming. There's a risk of peel injury and microvascular injury. And all of us have probably been there where we were perhaps a little aggressive in splitting the fissure, and there can be some peel injury. And so there is at least a concern, but I believe the benefits vastly outweigh the risk of complications if done properly. So an article just came out last year talking about how the sylvian fissure is actually formed in embryology. You start out with a flat area here in blue in the 24-week-old fetus, and then as the brain grows, the sylvian fissure decreases inversely, unlike other sulci and gyri of the brain, which grow in a direct proportion in embryogenesis. So this is Roton's exquisite picture, diagrams and dissections of the sylvian fissure. How much to split the fissure? That is the next question. And I always say as much as you possibly can, as much as it gives you additional space, because it relaxes the frontal lobe. Anatomically, I'm just going to briefly go quickly through this. It consists of a stem, which begins down in the anterior perforated substance to the temporal pole, and then laterally divides into the several rami, the anterior ascending ramus here, anterior horizontal ramus, and the posterior rami. These two delineate the pars triangularis, and then the insulopercular part, which is back here. So not all fissures are the same. When we are allowing our residents to split a fissure, we would hope that we can start on something like this, the octogenarian with a very patulous fissure, but some of them are like this. John Fox wrote that sometimes the fissures appear to be very undissectable, but as you get deeply into them and move deep, they become easier, and it once again opens the world to you. So the goal: release the frontal and temporal lobes as completely as possible. Dynamic retraction only. I no longer, as I was taught back in the dark ages, to place retractors on both sides. You just retract with your suction, plus or minus with patties. Widely open the corridor to the paracellar and subfrontal areas, and use sharp dissection whenever possible. Gentle bipolar spreading. These are just some techniques. Teasing the arachnoid with jeweler's forceps, I'm sure that all of us use. Gentle dynamic retraction using micro scissors and arachnoid knife. And the other thing is, if one technique doesn't work, if you find that teasing the arachnoid is tearing the pia in a particular person with a very friable brain, then choose another. Use the arachnoid knife or micro scissors. And then starting proximal. Some people start proximal. I usually start distal, quite far distally, superficial to deep, deep to superficial. I try and avoid mannitol and CSF drainage if at all possible to keep the fissure full at the beginning of the case. I split the fissure for Acom aneurysms, for MCA aneurysms, carotid aneurysms, you name it. I split the sylvian fissure just because it's such a gratifying technique to be able to move the brain gently with the suction without tension. So let's just go into the obvious cases where you would split the fissure. An MCA aneurysm, sylvian AVMs, insular gliomas, and then the less apparent times, medial sphenoid wing meningioma, olfactory groove meningioma. Who would think of splitting the fissure for that? The classic technique is interhemispheric or subfrontal, lift the frontal lobe. But you'll see by splitting the fissure widely, you can get access to cellar, paracellar lesions, even supracellar lesions very nicely. What tools? They're the basic microsurgeon armamentarium, the round knife, the sickle knives, the Yazergill round knife, the bell tip suction, micro scissors, jeweler's forceps, and a bipolar. Let's see here. I think a couple of videos now, and everyone will recognize this as a Professor Yazergill dictum. Okay, this is slicing the orange, right? So you're peeling away the cranium first, and then you open the dura, and then this is the dura being opened. But then the dissection of the sylvian fissure, as Professor Yazergill said, is not, it's like trying to open an orange. You don't pick a little crack in the orange between the wedges and try superficially to open it up. You stick your finger deep in once you have an opening, and you split it from the inside out. And so that's the way to open the sylvian fissure, by going deep. There's the expression duc in altum, go out into the deep, stick your finger in and go deep. It's also what a football, go deep. So this is a case from a number of years ago, and I'm really not going to show you the case itself or the ultimate outcome. It was an approach, I think, to a paraclinoid, ventral paraclinoid aneurysm. But just starting on the frontal side, this is frontal, this is temporal, using the arachnoid knife. This, I didn't have a bell tip suction available. It's all I use now. So you get an entry. And you saw when we started, there wasn't translucent arachnoid. But then once you find an artery, such as this, you go deep. And you go deep with the bipolar, you go deep with the suction, and gently tease the arachnoid. If there is a vein, a micro vein that you have to sacrifice, it's okay. But you'll see the arachnoid strands holding artery to vein, brain to brain, all kinds of different connections. And they require different techniques to release them. So this was getting down near the optic nerve and the carotid artery, going over the olfactory here. And I don't think I'll go any farther other than to show you that the Sylvian fissure, as you can see, is very nicely relaxed. And, you say, well, why would you do an Acom aneurysm this way? You're nowhere near the anterior cerebral artery if the thing ruptures. Well, you do it right. It doesn't rupture. You go down here, you relax everything, and it's much nicer to get control right here with the Sylvian fissure wide open before, rather than just sticking a retractor under the frontal lobe and lifting up the frontal lobe to see the Acom. So this was another case. Trying to remember what this is. I think it's another. It's an Acom aneurysm actually, and again, starting to split the fissure there near the rami of the fissure laterally. And here you see it looks like, boy, this is. How are you going to get into that fissure? There's no arachnoid at all that you can see, but with a little bit of dissection and sharp dissection, you don't see, me sticking a Roton 6 in there or a hook or anything blunt. It's really just the bipolar, the suction, and sharp dissection. And as you separate the frontal from the temporal lobes on high magnification, you see you can go deep. It opens up. As I was describing the folding of the inferior frontal gyrus and the superior temporal gyrus over the Sylvian fissure, it traps the open fissure underneath. So even though it's stuck like glue at the surface, if you can get through that without creating significant peel injury, then once you get deep here like this, it becomes fairly straightforward. So let's go to the next case. And this is, I think, just this is an aneurysm that had been sent to us after having been coiled, just kind of your run-of-the-mill middle cerebral artery aneurysm a couple of years ago. It was done at another hospital. You can see the neck of the aneurysm right here on this 3D CT. Probably not a coilable aneurysm, or one that would be better treated clipping. And this is the initial coiling result, which looks very satisfactory. And this is a year later, where you can see how the thing has recurred at the bottom. It's just not possible to deal with this aneurysm without a very wide splitting of the Sylvian fissure, so that you can see the distal MCA branches, the proximal MCA branch, and the aneurysm, the entire aneurysm itself. And you'll see when you do split the fissure widely, not only at the normal place here, but going back as if you were going to expose, the entire insula. As you do so, the frontal lobe and the temporal lobe very nicely separate. And I'm just going to fast forward here till to see the lesion with the coils in it. You see no retractors here, just the frontal and temporal lobes completely laid apart, and ended up, cutting and removing these coils. And at the very end, you see sort of the Sylvian dissection. You see the aneurysm clipped off here, the base of the aneurysm here, and you can see once the cottons are removed how widely split the fissure was. And then just very briefly, a couple of other cases to show you sort of taking it, why would you split the fissure for a craniopharyngioma? I mean, this is another case that when we were removing this, we thought anytime, and this is sort of something that we do in all of our cases, anytime there's a very calcified lesion at its base here, anytime we're getting near the clinoid, anytime we're getting near the medial sphenoid wing, we're going to split the fissure. And that way you get facile and you get more experienced with it. This is just the end of the case, showing the craniopharyngioma down here, the A1, the M1. As you zoom out, you can see what a wide splitting of the fissure is. Here's the M1 all the way out into the insula, and the tumor was down here with the optic nerve. And then lastly, another case that really is not a typical fissure split case is a big olfactory groove meningioma. And Sammy wrote a few years ago of their extensive experience with dealing with these from a terminal approach, and really about the only way I do these anymore. And again, the standard thought is, well, it's right here under the skull, just go at it from the frontal approach. But by going at it from a terminal approach with a wide splitting of the fissure, you get a tremendous vista all the way, again, depending on the consistency of the tumor as well, all the way to the top of that tumor. I'm just going to show you briefly at the end of the case. This is sort of the meningioma being resected, what kind of an opening you can have. So this is the end of the case. And again, the fissure was split, no retraction to remove this lesion. But again, not a typical lesion you would think of splitting the sylvian fissure for, an olfactory groove meningioma. But if you read Sammy's reports, they widely split the fissure for every one of these. So in summary, just begin where the frontal and temporal lobes are in apposition, where you see transparent arachnoid. Stay on the frontal side of the sylvian veins if you can at all possible. Go deep, ducum altum. Gently spread the lips of the fissure from inside out, applying pressure to both walls. Keep the peel surfaces intact. Use the arteries as your guide to the fissure. It's a useful tool in approaching diverse pathologies in the paracellar and subfrontal areas, interpeduncular cistern, the medial temporal lobe, even the medial sphenoid wing. And you'll find once you see this, that you will use it on more and more and more cases. Use the inside-out technique, keep the peel surfaces intact, and use your arteries as a guide to the fissure. And remember God's cincture. Okay.
Paul, that's terrific. What a nice mix of history and technique and skill. I'm sure this is very well received by everybody. Thank you so much. As you know, the format is we're going to listen to everybody first, and then we accumulate the questions. Beautiful. So now let's hear from David, who I guess David's going to say you're doing it all wrong, Paul, because David says he probably has no role for the microscope anymore. But of course, I'm sure he still splits the fissure. But anyway, David, all yours. Tell us why the future is now with the exoscope.
There is no role for the microscope anymore. I mean, I say it. I really believe that, actually. So I decided to actually put a new talk together for this, because to show not just some of the extreme vascular cases that I've done with the exoscope, not just to show what can be done and should be done, but the opportunity I think the young neurosurgeons of the world really have to benefit from this incredible device. And I'll start my, thank you for, I think that I tell people all the time that COVID has given us, COVID's been a great thing. Ultimately, it's going to impact our ability to train, our conferencing, learning. It's just incredible. I think, when very early on in COVID, I saw these virtual talks as such a valuable asset. But there's no one better than Jacques Morcos because of just your relationships, your people skills, your incredible knowledge, and the fact that the way you've organized these things over the years. This is just the ultimate weapon. And I don't think personally anybody should even try in skull base or vascular, because you've mastered this medium and you deserve a lot of credit for that. I think you fully take advantage of it. You've organized this in such a great way, and we're blessed to have you. I think there are a few people that could have pulled this off at such a repetitive way and be really persistent with your great team. One thing I saw your fellow Nicky with the pen tie. I think he had a pen tie on. Love that. And also, I've known Carolina. I met Carolina when she was in New York. Chandra Sen spoke so highly of her, and she ended up with you in really just such a wonderful place. I've known Bobby Stark since he was a medical student, and I haven't met Michael, but I'm sure he's equivalently as talented. And Jacques, you've managed to surround yourself with great people, and it's a credit to you and your your creativity and your hard work that you've been able to do this. So congratulations, and thank you again for having me. I sort of agree with everything Paul said about the fissure, and I also want to point out the importance, before I talk about something I do, is just the importance of great teams. I've become a huge proponent of this, and as you get older, the Einstein fraction that ego equals 1 over experience. It's so true. And I got to thank every one of my closest friends and colleagues here, the original core 5 of us that really started the Lennox experience: John in the front, Rafa, Jason Ellis, and Mitch. They're all really a part of this. And I couldn't have gotten away with doing some of the things I do without a group of people that I knew would have my back and wouldn't criticize me or say I'm nuts, which I am. But you have to have great colleagues to be creative and innovative, because there's too much at stake and you're going to make mistakes, you're going to fail. And you have to have people that respect you and know what you're really about, that you feel confident in M&M and do these things with the right purpose. And I think we also have 2 additions to our team at Lennox: Dave Gordon and Yafel Sarul. Dave comes from NYU, Yafel down from Miami. He used to work a lot with Bobby, actually. And I just want to point out that these guys have all contributed to this talk in their own unique way. So the microscope, I love this picture. I'll get back to the picture in a second. This picture of Harvey Cushing at the Brigham around 1928. You can see this nurse on the right writing stuff down. It's like a rep or something. Maybe she was selling like, I don't know, gauze over your face. Then you have his assistants. This is actually the first electrocautery surgery. You can see the electrical box off to the right and where his assistants are. And you can see the gallery sort of stretching and trying to see. But the ability to see and illuminate has really been the biggest challenge of neurosurgery from its inception. And I would argue it's impacted not just surgical training on your own, but how you train a resident, how you work with your partner, how you share the experience, how the whole team experiences the surgery, so they can be not only an asset to you, but can contribute in a substantive way. I think the microscope's gone through evolutions. Obviously, these are wonderful devices. I'm a huge Leica guy. I have my own preference. I used to have my own preference with these devices. I think they're wonderful instruments. Take nothing away from the beauty of them, but frankly, there hasn't been that much that's really changed about the essential optics and illumination, probably in about 10 or 15 years. What's gotten better is some of the dyes and the stains and the different UV cameras, like the computers these become big computers, robotics. I don't think the robotic aspect of the Zeisscope has really accomplished all that much. And in fact, I think this is the device I use, but what does that leave us? There are multiple exoscopes, and there are multiple options for the neurosurgeon. So how do we sort of wade through this? Because I do think I've not used the microscope by choice in 3 years. I've had got the Olympus exoscope in my shop in end of 2017. I've not used the microscope by choice. I've had to use it because the exoscope wasn't available or as an assistant, but I haven't used the microscope in 3 years as a choice. And there's a reason for that. I just think this is a uniquely better instrument, and I will try to explain why. Microscopes were introduced really not until the 80s. Gene Flam, who taught me how to use a microscope, was a Yassergill disciple, brought the microscope to New York City in the 1980s, actually. Pete Janetto is a story of Janetta wheeling a microscope around LA with Bob Rand, trying to do microvascular decompressions in the 70s and 80s. But like I said, there's been no real quantum shift in the actual essential microscope technology for quite some time. What we're seeing now is these add-ons, the recording, ICG, ALA, navigation, robotics, digitization. The scope itself is basically the same. In fact, I think sometimes we take step backs because we have to increase the size of the head because of adding these new technologies. And I really believe that we're sort of at a fixed state with the current microscopes. This is what a room looks like now. In our room, this is an aneurysm operation. And I think what's so cool about this is when you come back to the Brigham in 1928 and compare it to Lennox in 2018, so 90 years later, you have this person writing stuff down on the left. That's a rep who's writing something down. I don't know, I like that nurse or that rep in the Cushing picture. But instead of the view, the gallery looking over their shoulders and trying to squint to see something, you have our gallery all wears 3D glasses and seeing what the surgeon sees, not to mention the OR tech and my assistant. This is just only one small benefit for the room. And the beauty of this thing and the gestalt and the environment and the immersion that everyone feels when this is set up properly. You know, we wrote about a review of the current platforms. This came out in operative neurosurgery back in 2018, the end of 2018. I had about a year's worth of experience. I hadn't tried all the scopes yet, but I've made a real effort to try each one. On the upper right is the using the Synaptive with the voice activation. On the left is I just recently tried the EOS, and I actually, on the bottom is I brought 2 exoscopes into the case. I did this with Synaptive also, with 2 screens, the EOS, and here was the EOS screen on the left and the Olympus exoscope screen on the right, just to, you know, sometimes when you use one, wow, this is amazing. And then you kind of, it's like the last person you interviewed, that guy was the best or woman was the best. You know, you have to put these things side by side and learn about them, including the microscope, I would add. Each one of these has its unique advantages. I don't think any of them are bad devices, but when you go to look at an exoscope and think what's the best one, since we're talking about vascular and skull base, I think your specialty matters. What you're doing, are you doing spine or are you doing, you know, deep cavernomas of the thalamus? You know, what's your operation you're most likely to do? I think the optics matter. They're not all the same optics. The price may matter. If you're a mouthpiece surgeon, I don't think any of these things are going to work very well unless you're going to get into the voice activation of Synaptive. Navigation may or may not matter to you. The company culture, each of these companies has its own culture in the way they engage neurosurgery. I think Olympus is new to neurosurgery. The EOS with Escalab's old to neurosurgery, and Synaptive is relatively sort of in between. And then how the assistant experiences, how the room experience, all these things matter. And for that reason, each of these devices has its own strengths and weaknesses. So what I thought I would do, I've done, this is about up to almost 300 cases now. I've done, you know, everything in vascular with this. And, you know, I thought I would just show quickly, just some quick videos of what this looks like. You know, I think there are huge benefits. The surgical ergonomics are extraordinary. I'll show you a sitting case. I'll show you why. The size of the scope is with the exception of the Synaptive and the EOS are larger. The footprint of the Olympus is incredible where you can put it and how you position it. It's much easier to sterilize. The nurses, you don't run into a nurse that can't do this or can't figure it out. The education for the room is extraordinary. Also for your fellows, I constantly take in ideas and thoughts from everybody in the room because they're seeing what I'm seeing. One of my fellows saw when I'd open up an anastomosis, when I'd opened an arterotomy, I got a hole in the back wall. I didn't see it. He saw it. And that never would have happened with the microscope. It's just too uncomfortable to sit there and concentrate the whole time with your neck bent over and you're in 2D. And so now I have a much more open operating room. Everybody contributes and offers their perspective, which is truly wonderful. Also, navigation can be incorporated very simply, whether it's non-integrated with a picture-in-a-picture with the Olympus or the full integration with Synaptive. They also have, because of the nature of exoscopic digitization, the field of view is larger and the working distance is greater. So you don't have to refocus as much. And I really believe it's an unparalleled operative view. There are nuances. You know, you have to worry about screen placement, and the concept of sight lines comes into play. You have to worry about the surgical sight line, the assistant sight lines. I had to radically change the organization of pretty much every type of surgery: prone, supine, left, right, spine versus, you know, a carotid. You have to almost readjust where everybody sits and where the scope is placed. And there are, you know, variabilities to this that you can work through. And I think all these things matter because you can't just walk in as a microscopic surgeon and just expect to like pick this up and figure it out and love it. Unless you go through this or have somebody helping you and telling you what they did. You know, neurosurgeons tend to really believe in themselves. There's a certain amount of cultural ego, and it's not a bad thing. But to make this transition, you're going to have to let your ego down and, you know, get some advice about the best way to set your rooms up, because it ain't going to work if you just do it the old-fashioned way. You know, I saw a talk by a guy named Seth Stevens-Davidovitz, he's basically a data analyst, internet explorer, amazing guy. He's basically a sociologist who gave a talk on data. And he basically what he did is he looked at the social media posts of women about their husbands and compared those to the Google searches of their husbands. The social media posts were most commonly, my husband is the best, my best friend, amazing, the greatest, so cute. Whereas the searches were my husband is gay, a jerk, amazing, annoying, and mean. And I always say, you don't want to live an Instagram life and you don't want to live a Google life. You want to keep your eye on the boat. But by the same token, I think part of the reason why people have struggled with this is that when you're operating, everybody sees what you're doing. You can't lie. You can't hide behind the microscope. That when it's open, if you screw up, everybody sees it. And you have to be confident enough in yourself to allow people into your world. This has an amazing impact on medical students to see the brain experience surgery the way we did and we had that 30-second view for the first time. Let them see the whole darn operation. The impact is enormous. I really believe this is going to convert more medical students to our business, especially spine. No one can see a spine operation as a medical student. This lets them in, and it lets them see everything, because spine, when it's done properly with magnifications light, is an exceptional thing, and the students love it now. They love to watch this stuff because they can really see. And that's the beauty of exoscopic spine surgery and exoscopic cranial surgery. This is the problem with the assistant. You know, when I took these pictures in our hospital, this is insane, especially when you're assisting and trying to teach. It's uncomfortable. I find I can teach, I can sit back, I can sit on my chair and just watch from 10 feet away. And I enjoy the surgery. I like watching my partners operate when I'm assisting. And you're comfortable. You can contribute as a mentor. You contribute as a partner, as an attending, and not be uncomfortable and just really see the surgery for what it is. And I find I'm much more involved. It's not uncomfortable for me. You can concentrate more. And this is a huge benefit, something that we never even thought of before as far as the microscope goes. So I'm just going to go through a few vascular cases. This is the setup for a carotid endarterectomy. It took me some time. This is probably was the most strenuous in figuring it out. And then in the OR, it looks kind of like this. You're kind of looking over the microscope. This exoscope, the Olympus, you always look over it. Synaptive, like, should look under it, and EOS is somewhere in between. But the Olympus is best served at a working distance at about 250 and 300, because the arm is low profile. You can look over it. I would also point out the angle of the scope versus the angle of your neck. In all these pictures, the angle of the scope is normally the angle that your neck takes. One of my closest friends is a pediatric heart surgeon, retired at 53 because of severe radiculopathy. I have a little kyphosis already, and my neck does not hurt anymore after giving up the microscope and giving up loops. I don't use loops anymore either. You can actually put your loops on and put the big 3Ds over it and use them if you want to. I just don't even use loops anymore. And this is a typical carotid. I do it skin to skin. This is a great way to learn how to use it. It gives you the haptics and the feel of using it right from the beginning. And I'm just doing the skin incision, going all the way down, coming all the way through, doing the entire surgery. I'll brush through this just to accelerate it. I'm doing the entire operation with some guys close the microscope. Some people use loops still, but this is the visualization, the angles. I can look right up the barrel of the lumen, which I think is very hard to do unless you're really bending over with loops. And with a microscope, the gear shifts often hit the table when you really drop it down. So I can look straight up the lumen and make sure there's not any adventitial, loose adventitia or stenosis beyond my, when I pull this out. And I think that this is a unique thing that, didn't come to me right away. When I got into this, I was thinking, oh, just cranial. I didn't even consider spine surgery. But even for those who do spine surgery, things like L5-S1T lifts, the angles on these things can be really severe. And it's hard on your neck. You can see this angle. It's hard to tell here. It's hard to get this angle with the microscope. And if you're doing with loops, you're literally looking like this. And I watch the vascular surgeons and I kind of chuckle about it. This is the position of an aneurysm, similar picture from before. And I'm going to show you two really challenging aneurysms, not like just here's a small PCOM to clip. This aneurysm we did about 8 months ago, a ruptured aneurysm. It was not appropriate for pipe in a ruptured situation. We weren't going to sit on it and wait or do some crazy thing. It turned out there's also a trigeminal artery here for those anatomists. This was the 3D. It had a really narrow neck. I thought this could be clipped. In general, we're gonna treat these with interventional approaches, but in acute setting, I think that sitting on this and letting it cool off and putting pipes in, not going to happen here. And this is the case, with the exoscope. So I agree with Paul. I start every case distally, and I'll again scrub through this to get down to the nitty gritty. So this case involves suction decompression. It involves clinoidal resection, stacking clips, and this is all through the exoscope. I do put retractors in at the end once I get the Sylvian fissure split, particularly for drilling. I love the Apex knives. I know Paul, I saw Paul using the round one. I like this back cutting one pretty much for everything. I think Apex knives are wonderful. I use the NSK drill. I think that the drill actually doesn't kick as much. It's much smoother. So we do a full clinoidectomy to get proximal control here. I don't think having just neck, and here you're seeing, this is a 1 millimeter diamond on the cavernous sinusoid. You'll see a little cavernous bleeding here in a second. Now I have the full clinoidal segment through the dural ring. I'm gonna fully trap this aneurysm and then suction decompress it, fully trapped. Here's the ophthalmic artery just to keep it totally. Suction decompression, fenestration. We didn't get the fenestration quite down far enough the first time. I'll just show you the final clip position. So here's the final clipping. Once you suction it, usually you get enough blood out of it that it won't refill as long as you're trapped. And then the second fenestrated clip. But these are, these are varsity cases for vascular. This is all exoscopic. And there's no limitation. You see everything you see and more with the microscope. There's the final clip position, temps off. Final clip. This case is a ruptured P2 aneurysm. This is an aneurysm too small for coils, had a diffuse subarachnoid hemorrhage. You can see that we didn't see an aneurysm on the original. I draw your attention to right here. We did not do a 3D, which we probably should have on the first time around, but there was nothing obvious. We repeated the angiogram at day 6, but there's really nothing back there. On the day 6, if I draw your attention to right here, the double density, again, it's just, there's nothing we obviously can see, but here's day 1 and here's day 6. We did a 3D, and this is the aneurysm on the back of the piece of the P2, basically, the P1, P2 junction. Exoscope, this case was done with the exoscope, like no problem. And here's the same thing. It's an OZ, splitting the Sylvian fissure widely, as Paul mentioned. Again, I open the lamina terminalis for CSF control. Now I'm going to show that this actually ruptures. I've got the PCOM, that's the P2 here, third nerve. The aneurysm is down in here. I'm just dissecting as I went back and looked at this, like, I just over dissected it here. Starts to bleed. I don't have great proximal control in this case, obviously. We have adenosine in the room. I'm going to play this in real time to show you the movement of the exoscope and the bringing in the assistant. So my assistant comes in with a larger sucker. So I've got a ruptured P2 aneurysm here. We give adenosine to slow the bleeding down. This is with Erez Nosek was with me on this case. This is a number 10 sucker coming in. I must say I had a fair amount of anxiety here. This is I didn't have great exposure here of the basilar. And, I think Ali Krish probably would have the transcavernous. This was potentially very dangerous. But I'm showing it. So there's no editing here. This is real. So I'm coming in with I knew where I had to get the clip, have a long, straight Sugita clip. Now watch, I'm able to key my left hand in, and if I'm a mouthpiece surgeon, I know you guys laugh, you can move with your mouth. I'm coming out with a clip, gonna move the exoscope with my right hand. Autofocus. We gave another shot of adenosine. And now I've got the clip angle I need. I just needed a little bit more on the optic nerve side. And have the aneurysm now. and we were done. Doppler, etc. No stroke. Patient did well. That's the final post-op angiogram. You can see where the clip was. Bypass, I obviously love doing bypass. I thought I'd show some tricky ones. This is a Moya case, multiple strokes. I won't bother, but you can see the Moya. Spec defect on Diamox. I use Nova for every case, 58 cc's in the left MCA. Relatively poor collateral, only 13 or so from the PCA collateral, 92/7. I'm sorry, 13 cc's extra on the left PCA, only 5 from the ACA. Everything's through the exoscope. The harvest, the craniotomy you can do. These make for great teaching videos also. Everything's done to the exoscope. Cranie, the bypass, the vessel harvest and the adventitia. You can see how beautiful these videos are. Just want to point out one little trick I learned from the Japanese guys. Basically, if you put this, that's the 12 o'clock stitch at the toe and the foot. You can put a needle in your first stitch on essentially the back wall and leave it there. That's the heel. So I like to do this, especially when they're really for MCA by these Moya cases. Just leave the needle there. It holds your back wall away, and then you can just do the front wall. It just tense that back wall away from the front wall. Works great, and I'd really recommend this. These are Scanlon instruments. I've actually switched to Charmant recently. I really like the Charmant instruments. The needle holder and the tying forceps is even tighter than the Scanlon. Obviously, we're just going to recirculate, and you're good to go. This is probably
video of an internal.
This is probably the largest aneurysm I've bypassed. I think some of you guys have seen this. This is like 10-centimeter aneurysm with this flow channel inside of it. This is just the flow. This area of bright signal is the flow channel inside of it. You can see it was like almost this is the M1 sort of way elevated. You can see how the ACAs are all pushed over. And this is the flow channel. And this is our bypass point. This is actually relatively simple, ultimately. A bypass and a distal deconstruction. There's even a Sylvian fissure we could operate through. And I like the IMAX for this because the IMAX is great for MCA flow replacement. Here's that, again, that flow channel. So we did an IMAX graph with an anterior. I love the anterior tibial artery. It never spasms. It's just so reproducibly terrific. You can see the size of this thing. So our plan was bypass IMAX to MCA, distal occlusion, and come back and take this proximal portion with the, this is a Nova showing 85 cc's in the M1, which is a lot. You know, sometimes there is low flow, and then that's why I chose an interpositional graft. But here's the setup in the OR. This is a left-sided cranie, so the screen's on your right, exoscope coming over my left shoulder. Here we're finding the IMAX. This is the orbit. Here's the IMAX and the infratemporal fossa. You can see the amount of flow we get from this is just terrific. We dissect down to the M1. Now we've got the anterior tibial artery here. Same technique. I'll run these usually. We'll run in general, I'll run this rather than interrupted. I'll do the distal first so I can flip the graph back over to get the IMAX. So here's just see the flow coming from IMAX here in a second. I'll just bring this. So you clean this. I had to fish mouth IMAX a little bit here because it was about 2/3 the size of the interposition graft. You can see the flow you get from this. You can't really measure cut flow from this. It's tough. But I haven't, they're almost uniformly, 50 cc grafts after putting them in, at least. So now I'm just going to go end to end here. You can see the visualization with this. The reason why this is so great is it's so shallow to operate. You're not in the neck. So it's like this is easier than pretty much any anastomosis you'll do, just because you're using, look, I'm using jeweler's forceps for this. I'm really short. So when it's all done, the great thing is with this, everything's in your operative view. You're not down the neck and assessing the graft the neck. And I'm just going to quickly put a permanent clip on the distal M1, the distal MCA here. It's just a permanent straight clip to put demand on the graft. And I've got the whole thing in my field, measuring flow with the Charbel flow probe, ICG angiogram. What's amazing about this is after here, you can see with just the clip, that whole flow channel is gone, just from, there's no demand, no outflow. Now we just went ahead and coiled this big sort of patchless thing. Whether we need to do that or not, I'm not sure, but I think it's good to get this to thrombose as quickly as possible rather than waiting for it to go on its own. And this is the A1 wrapping around that. This is just a sitting case. I draw your attention on the right to the angle of the exoscope here. Their sitting is just freaking incredible. That you can see things. This is looking over. This is a dural fistula right at this level of the vena Galen. They need a simple clip. And you can see the view of this, the tentorium, and I'm comfortable. I'm not like bending down and all out of sorts looking high up there. This is where it really shines when you have these angles. Again, I look at the angle of the exoscope versus my head, and you can imagine if you did microscope in that position, the position you'd have to be in. This is an example of in the OR, the concept of immersion versus submersion. I think that I think of operating with a microscope like operating on a periscope in a submarine. You see everything, but it's round and you see this dark ring around you. This is immersive. The screen, the large screen, at the edges of your visual field, you don't see them. You see light, but it's not in focus. And I've tried to understand why this is so much more kind of enjoyable. You don't have that black ring around you. It's almost your entire visual field is full of the information you need to operate. The Times wrote about this. They came and spent the day with us. But we as neurosurgeons need to lead the way in these new technologies. And it's important for young people to be innovative, take risk. This has been, I think, one of my most enjoyable things I've done. I really look forward to using it. There's no question in my mind it's going to be disruptive. It's just a matter of time. I don't think it's going to totally replace the conventional microscope, certainly not in the next few years. But I would imagine within the next 20 years, we're not going to have microscopes anymore as the younger generation adopts this and learns on it. There's really no use for loops either. Loops are bad ergonomics, not as good a light. You hit heads and spine, your light's all over the place. I think for mouthpiece neurosurgeons, it's going to be tough. It really disrupts your workflow. I don't think it's easy to do, and I wouldn't recommend it. The transition for a foot pedal neurosurgeon like me was very easy. But if you're a mouthpiece guy, I caution you because your whole, feng shui is going to change. Fatty pointed this out to me. He noticed that in my videos, I'm not always in the center. And it's true. When you're a foot pedal surgeon, you get to being operate in different quadrants. You're not way offline, but I'll be okay, a few, 10, 15 degrees off the center. The mouthpiece surgeons aren't. And if you're not comfortable with that, you can't do this. Now, I would argue that the Synaptive, which is a voice activated, solves that. But after using it, the voice activation is very cumbersome. I found myself talking to things is not what you want to do while you're operating. You get into your zone, you don't want to start giving things voice commands. I don't think voice commands are going to work. I think the future is probably following instruments or something like that. So it's a little bit more, we're still, I think, a few years away from that technology. I think it has application in other fields. It's a major improvement in teaching and communication, massive. And it's a greatly improved visualization for navigation. So that's it. I hope I didn't go over time too much. Once again, thank you, Jacques, for this opportunity to speak, and appreciate all you do for our great specialty. Keep going. we all cheer for you and love you and appreciate who you are in our business. So thanks again.
Thanks, Dave. This was again terrific, and I am sure you're going to generate a lot of interest and hopefully lots of questions from the audience. Exciting stuff, and we can talk about it perhaps later at the end. Beautiful, beautiful cases too. Giuseppe, you're up now. David, if you could stop sharing the slides. Now, Giuseppe's gonna, for something perhaps a little different, is gonna talk to us about his vast experience with intracranial dural AV fistulae and perhaps a multimodality approach, or perhaps endovascular. We're gonna find out.
Thank you, Jack. I like to echo what has been said. Congratulations to you and the Miami team, and thank you for having me. I like to briefly discuss some few cases to really exemplify and bring the message that, especially with dural fistula, but nowadays for most of the things we do in cerebrovascular, the fact that we have different tools, different way of fixing the same problems really has shifted a lot of the importance to the decision making and the choice of the strategy. Now, with the dural fistulas, a lot has changed since my predecessors, less than 40 years ago, published really this landmark paper. And if you read this, you will be surprised to find that actually there were a couple of cases of patients that died because of blood loss during the surgery. And you can imagine some of the most complex fistulas in those days with no endovascular techniques, and the understanding of this pathology was not quite as advanced as is today. You can understand how that could have happened. Now, when we think about the factors that affecting our treatment in dural fistulas, well, symptoms, type, and of course, presence of symptoms, the angioarchitecture of the fistula, and the location. And also, often these factors are all connected to each other. And as I said, when you have different therapeutic options, it's great because you can really tailor your approach, but it can also be dangerous if you, for whatever reason, you constrain yourself to one particular strategy and you ignore the other. And when we think about in very simple terms, what drives the choice, or what should drive the choice of our therapeutic modality, as far as I'm concerned, safety comes always first. And then I look at the modality that is the most effective. And then nowadays, there is no question that how invasive that modality is as important, as our patients are often not often, but they do have a very important role in the decision making. So as I said, I'll use a few case examples, and then here and there, I will discuss a few basic concepts. So this is a classic, straightforward case, 69-year-old with the history of progressive neurological symptoms, no history of hemorrhage. So here, the issue is her age. And you can see that on the MRI, you see this sparse, dilated vessels that indicate most likely this patient has a fistula. This is a lateral tentorial fistula, and you can see that there is a venous varix along the petrous ridge at the level of the dura. And the other thing to remember here is that, yeah, these fistulas, it's true, they are different from each other in terms of symptomatology, angioarchitecture, but at the end, if you can understand the anatomy and decodify in relation to different locations, they tend to be fairly similar and often relatively simple. So in any case, here is the angiogram, external carotid artery injection. So as I said, the key here is that this patient is 69, and actually she was referred to us after failed embolization elsewhere, but this was really a very difficult angiogram, and she has vascular risk factors. The other important observation here is that you can see the fistula, everything seems to converge in that to this venous pouch that we saw on the MRI, but the main feeder is the petrosal branch of the meningeal artery, which also provides blood supply to the facial nerve. And here you can see the complexity of the fistula. But as I said, if you really decodify the anatomy, they are fairly simple to understand. And in this case, we didn't feel that embolization was a good choice. Number one, it was really, we really had a hard time to get a very good, stable position of the catheter. There is the issue of the petrosal branch and the implication for the facial nerve. And nowadays we can use a lot of tools. Here is the expert CT based on the angiographic runs that basically it tells us exactly where is the origin of the fistula. And as I said, after you see a few, you can see a pattern, and this lateral tentorial dural fistula have a fairly typical anatomical location as well as appearance once you explore. So the fistula, you can see here the prior embolization. The fistula might look very complex, but at the end, once you decodify the anatomy, the treatment is rather simple. And as we know, the key is the occlusion of the proximal segment of the arterialized draining vein. And this lateral tentorial dural AV fistula have exclusive retrograde venous drainage. In the past, we used to say, if you look at Isama Wad classical systemic review published in 1990 in Journal of Neurosurgery, there were 30 out of 34 tentorial dural fistula that had presented with the hemorrhage. Nowadays, it's not that uncommon that we found them in patients with progressive neurological symptoms without hemorrhage, but we see more and more often even incidental tentorial dural AV fistulas. And this lateral type typically involve the superior petrosal venous system. So, as I said, once you decodify in this patient, we didn't feel embolization was the best choice. Why? Because we had a fairly straightforward surgical solution, and you can see this is nothing more than a classic retrosigmoid approach. And you can see here is the tentorium and the petrous ridge, and you can see the typical, they have a classical typical appearance, all the arterialized feeders converging into the larger draining vein as it emerges from the dura. It's nothing different than an aneurysm. It's important to skeletonize the proximal portion of the vein, clean the arachnoid, but the treatment, it's fairly simple. It's closure, interruption of that proximal portion of the draining vein. These are very gratifying cases. You can see here is the post-op, the clip. This is not a hemorrhage. This is actually the thrombosis that you see on the CT of that large venous varix. And you can see after only 6 weeks on FLAIR MRI, there has been partial regression of the dilated veins. And you can see here the regression of this thrombosed venous varix, that it's like a scar, it retracts. And so now to bring home the concept that you cannot be really a prisoner of one strategy, I will show a fairly similar case, but with different characteristics. First of all, this patient is a 54-year-old who presented with persistent facial pain and pulsatile tinnitus. Again, a typical lateral tentorial dural AV fistula. Again, like in the previous case, most of the external supplies through the petrosal branch of the middle meningeal artery. And as I said before, you worry about the supply to the facial nerve, especially when you're going to use liquid embolic agents, onyx in particular, where you don't have a lot of control where the material might go. But unlike the previous case, which I said there was a very difficult angiogram in a patient with diffuse vasculopathy, in this patient, we were able, if you look the microcatheter on the right, we were able actually to almost to go from the feeding artery almost into the draining vein. So we were able to achieve a safe distal position of the microcatheter. And in this position, we felt very comfortable to embolize despite the feeding vessel being the petrosal branch of the middle meningeal, because you see, you easily feel that proximal portion of the draining vein, and now the onyx, it's in a retrograde fashion, closing some of those feeding arteries that go into that pouch. But you can stay fairly localized to the nidus and just the proximal portion of the draining vein. And here is the follow-up. So two fairly similar cases, but based on the age of the patient, the type of symptoms, and the fact that in one case the angiogram was very difficult, we knew we couldn't achieve a fairly safe distal position. We opted for one of the therapeutic options that are available. Now, this is another case that brings home a couple of other fairly simple concepts. Is a 52-year-old who presents with the progressive cognitive impairment. And here's the right external carotid artery injection. So this is pretty much, I would classify as a sphenoparietal fistula. And you can see the cognitive impairment is related to the fact that there is arterialization of the superior sagittal sinus. So for the younger colleagues, whenever there is impairment of the superior sagittal sinus drainage, both sides of the brain both hemispheres tend to be involved. And for some of these fistulas, typical are the ethmoidal dural AV fistula, a dementia-like type of presentation can be the case. Now, this fistula looks fairly complex, but I will show you that it's actually fairly simple. The problem here is that, well, you could immediately say, okay, nowadays, so let's embolize it. Well, most of the supply is from accessory meningeal arteries. There are anastomosis here with the ophthalmic artery, external to internal anastomosis. The vessels are very tortuous, so again, not very easy to achieve a distal and safe catheter position. But the question is, why take any risk? So here is what I like to bring home. The concept is that dural AV fistula, one of the reasons why they are also so interesting is that they can really present with any neurological symptom and sign known to mankind, because unlike arterial problems where the territory of the artery is fairly constant, this is a venous return problem. So patients can present with all type of constellations of different symptoms and signs. But as I said, where I said, why take any risk? Because this is a fairly simple fistula, although it might look very complex. And this is nothing but a pterional craniotomy. You open the dura, you have drilled some of the sphenoid wing, and this is the dura overlying the sphenoid wing, and it looks terrible because, of course, there are those myriads of feeding vessels converging into this single arterialized, calcified draining vein. This is the Sylvian fissure, and then you can see that, as I said, it's just a matter of doing the craniotomy, opening the dura, turning the dura flap, and then you can see here is the Sylvian fissure and the closure of the fistula. So again, a situation where the strategy and not being confined with what might have been the most convenient therapeutic modality becomes very important. Now, here is, I like to show this case because it illustrates something that we do quite frequently here at Mayo, but I don't think it's common in many places. And honestly, I don't understand why. So this is a patient with a disabling bruit. And you can see this is a typical Borden type 1 transverse sigmoid sinus dural AV fistula. There is no retrograde cortical venous drainage. The strategy here is that the question is, first, you really need to treat these fistulas. We know that the conversion from a relatively benign fistula to one that can cause hemorrhage with retrograde cortical venous drainage over time, it's relatively low. But this patient has a bruit. It's a relatively young patient, so you worry about the effects of a long-standing high flow venopathy in the changes they can induce in the return from the brain. So again, the issue of thinking through all the data that you have available. And what we do here, actually, it's fairly simple and 99% safe. So we do a transarterial embolization with the PVA. And the key here is to use particles that are larger than 150 microns. So why? Because the dangerous anastomosis between external and internal carotid artery, between the branches of the occipital artery and the vertebral artery, the diameter of those anastomoses is less than 150 microns. So if you use particles that are greater than 150 microns, you are unlikely to compromise those dangerous anastomosis. And the reason for transarterial embolization here is to take care of the symptom, which is the disabling bruit. And then we follow with the gamma knife. And this is a strategy, as I said, we have been applying for more than 25 years. Mike Link published it first in a Journal of Neurosurgery. And you can see the follow-up. And what's important here is that you see it's a strategy that it allows to consistently preserve the patency of the sinus. But more important for me is that you have immediate resolution of improvement of the symptoms. We have about a 90% or greater obliteration rate, usually within 1 year. But it's extremely safe. Why? Because with the gamma knife, you're just irradiating the bone. You know, the sinus, it's in the sulcus in the skull. So it's the gamma knife, it's very safe. And the embolization, it's technically very easy. It's transarterial external carotid artery embolization. It's usually occipital, sometimes posterior auricular and middle branches. We stay away from the ascending pharyngeal. And the key is to use particles that are greater than 150 microns. One last case, again, to illustrate the importance of the strategy. Sometimes you can just go for symptom palliation. 42-year-old patient with Down syndrome who presented with progressive gait impairment. There is edema at the craniocervical junction, but on flexion extension films, there was no instability. And you see what is the problem is this fistula was extremely complex. To this day, I could not completely understand. This is a combination of different fistulas. But look here, this is an external carotid artery that is the size of bigger even than the internal carotid artery. So by just simply providing some degree of proximal occlusion combined with partial embolization of that superior sagittal sinus, we were able to decrease the hemodynamic stress created with this fistula. The fistula is still there. We were not able to cure it. But look what happened to the follow-up. There is a resolution of the edema. There is a nice pocket of CSF now around that craniocervical junction. And her symptoms progressively improved within a few weeks of the embolization. So again, another case where we could have easily got into a major complication if we were going for some heroic cure. But in this case, I thought that just trying to decrease the hemodynamic stress and provide her with a few additional years of better quality of life was, at least in my opinion, a better goal. And briefly, this is just a summary of the series. As Jack said, we are lucky that for whatever reason, we see fairly large number of these patients. And again, the treatment is, in the majority of cases, single therapeutic modality. Occasionally, observation is the best option. There is no need to treat if the fistula is benign or the patient has a lot of comorbidities, but you can see that combination therapy has a very important role. And of course, embolization is the main share of these fistulas, followed by radiosurgery that we use exclusively for the transverse sigmoid sinus junction. It's effective in the cavernous sinus junction. My anecdotal experience is that radiosurgery is not effective for those fistulas like the tentorial ones, the ethmoidal fistulas, ferroparietal fistulas, where there is exclusive retrograde cortical venous drainage. Is much more effective when there is involvement of a larger sinus, and surgery, as you have seen in some of the example, still has a role. And the key, as I said, that as I'm getting older, the most enjoyable part of many of these cases becomes to devise a strategy of treatment rather than often the procedure itself. Here, the results, of course, we have had no hemorrhage, and this is always the most important thing. So it's been effective. Symptoms are improved or stabilized. And when we look at complications, you can see that major morbidity and mortality, it's acceptably low. And again, I think that a large part of these, consider these are all comers, patients with terrible fistulas, patients that have presented with bad hemorrhage. But the main reason I'm convinced is really the thoughtful strategy that we put into every single case rather than the execution of the procedure per se. Thank you.
Great. Thank you so much, Giuseppe. Very thoughtful and as expected. And of course, you have a vast experience with this. And thank you so much. Last but not least, Pascal, would you mind telling us, I guess David told us the exoscope is the future and it's now for microsurgery. Is neuroendovascular robotics the same equivalent for endovascular?
Great. Thank you, Jacques, for the invitation. It's an honor. Actually, Jacques is the most eloquent neurosurgeon I know. If you haven't read his two editorials, really, you should read them. One of them in Journal of Neurosurgery about George Floyd and his experience when Jacques was in Lebanon with the injured American soldier. And another one is about the late Evandro in ACTA, the brain whisperer. So you don't want to debate Jacques at a conference. He's so eloquent. I've debated him a couple of times, despite the fact that I was right. He made it look as if he was right. So that's the thing. And I cannot make fun of his accent because I have an accent worse than him, but I don't stress on the R too much. Anyway, so those are my disclosures, but the most important disclosure is, if you don't know, I mean, on this trip, I've tried my best to take a picture with my family, but always photobombed by Jacques. Like each time we go to take a picture, he's like in the middle and there. But you know, what can we do? So as a background, in stroke, the likelihood of a good functional outcome decreases tremendously every 30 minutes of delay in decanalization. And we know that around a third of the stroke patients get to a comprehensive stroke center a little bit too late, and mainly because all of the pre-hospital delays and patients would come in and they are ineligible for mechanical thrombectomies. And there are a lot of geographical disparities in stroke outcome, as you know, especially in the stroke belt of the US, especially in rural areas. And this is because of the, patients living in areas where they cannot get to a comprehensive stroke center early enough. We know from this great paper from neurology that under optimal conditions, a large proportion of the US population cannot access a comprehensive stroke center within 60 minutes. So what are robots? So robots are machines that can be used to perform repetitive challenging tasks or tasks that need extreme precision. And this is for one main goal is to increase human performance beyond the limitation that we have with our bare hands, or to be able to perform a procedure remotely. We know that the advancements in robotic technology came really late into medicine and came really late into neurosurgery. It's been introduced in different specialties earlier than neurosurgery, but the last 2 to 3 years, it has been a revolution in robotics, in neurosurgery in general. So what have we accomplished so far in stroke? We were able to work on many improvements, like devices for mechanical thrombectomies. As you know, as compared to the early generation devices, now we have more efficient devices that we are able to open vessels much more often. We have better screening methods because screening those patients is as important as doing the procedure. We improved on timing, streamlining the process, creating stroke networks. Telemedicine played a big role. Even before COVID, we were using it, and especially after COVID. Mobile stroke units, we're seeing them more and more. Specialized ICU care, and then preventive medicine. There are much more new generation medications to treat all those risk factors. But there's one area of uncharted waters that's going to be, it's about to be explored, and this is remote interventions. So you are all familiar with those robots, but what I'm talking about is a different robot. This robot doesn't look as cool as the ones I showed you, but practically this is what it is. That's the robotic arm, that's the console. So the robotic arm is hooked on the angio table to the guide catheter. The operator would sit at the console far away from the patient and would operate. This is the first coronary stent done remotely 20 miles away in India, December 2018 at Apex Heart Institute.
I am now directing the who has developed this logo and this style. A small branch, this looks good. And now I am using the knob to push my stent in.
So now they are deploying the stent.
Stent is coming out of the catheter in the coronary.
In the coronary.
You can see the comfort.
So there are two units. The first is the, as I said, is the console that's outside the INR room. There is a big high definition screen. And then you see here the joysticks. The green joystick is the one that would move the guide catheter. The C joystick is the joystick that moves the wire, and then the D joystick is the joystick of the device. The device, you can move it forward or backward. The wire, you can move it forward and backward, or you can torque it also. As you see here, you can twist it. And then the catheter, same thing, can be moved backward, forward, and twisted and torqued. This is how the console looks like. Those, if you want to make big movement, but if you want micro movements, those are, you can touch the screen and just manipulate with micro movements with that. So that's the robotic arm, and that's the disposable cassette. The robotic arm is hooked to the angio table, as I said. And that's the sheath attachment. So you're gonna take this and cover all the way the guide catheter and hook it to the sheath. And then this is where you're gonna load all your catheters and micro wires. This is an important little screen, which is the feedback. It will tell you at every step what's the next step to do. And then let me show you here. And this is after you open the cassette. This is where you're gonna load your micro wire, you're gonna load your device, and then the manual one comes here. There's a one for a manual wire, as you see it here. So it is user-friendly. This little screen I showed you earlier will tell you at every step what's the next step, what to do, what to open, what to close. So this work started really on animals, and Gavin Brits did a lot of work on animals using, trying to use this robot 2 years ago. Those are some of the papers that he's published. This is a paper where he embolized AVMs in pigs with the robot. And here I'm going to show you the prepping. Really, after the learning curve, it takes less than 5 minutes to prep the robot. That's the cassette. You drape the robot, you put the cassette, and this is, we're opening here all the ports. And here's the guide catheter, and that's the sheath that covers it and goes and hooks to the sheath. Here I'm going transradial. That's a snuff box here. And this is where you're gonna put your micro wire. That's the micro wire going all the way up here. And this is where you're gonna put your device. And then another one is the manual one. This is here showing some diagnostic angiograms with the Siemens catheter. I used the robot to shape the Siemens catheter in the arch. So as you see here, I'm just using the green joystick, and I can twist it, I can push it forward, and I'm shaping the Siemens catheter. One thing is the robot doesn't take any wire bigger than 18, so we cannot use a glide wire 35 or 38. That's why for diagnostics, we can catheterize proximal vessels, common carotid or vert. But if you're gonna go external, internal, you need to put the wire manually because we tried at the beginning to use an 18 wire, but as you know, it's very flimsy and you won't be able to do it. So hopefully in the next generation, we will be able to use bigger wires for that, and we'll be able to do a formal full angiogram with it. This is the first carotid stent that we did. It was a transradial. Here I'm outside on the console, and I have the pedal of the angio suite where I am, and I can use the pedal just there. And you're gonna see here, that's what's happening when I'm moving out there. That's Stav, my partner. We did the first case together. And then here we're bringing the protection device up, then bringing the balloon, and this is after the stent. This is the team. You can't do this without a team, really. They did a great job in getting used to the robot. This is a really nasty post-radiation carotid stenosis. As you see here, loading the wire. driving the wire up. You see here what's happening in the room and here what I'm doing. So here I'm taking the wire beyond the stenosis. Then I'm gonna bring up my protection device. That's the protection device coming up. Then I'm gonna unsheath my protection device. The spider, that's the spider. I'm unsheathing it all with the robot. Then I'm gonna bring the balloon. Here's the balloon. The balloon is up. Now they need to inflate it from there. So the balloon angioplasty is being done. Then I pull out the balloon robotically, bring up the stent robotically, and the stent is deployed from there. That's the final result. This is here showing really what's actually happening in the room, where I'm manipulating in the robot, and in the room you see wires coming in and out of the machine. Another case of another left-sided transradial carotid stent. Here we're forming the SIM2 catheter. Bringing the guide up. That's the lesion. Bringing the protection device, and that's post-stenting. And then it got the attention of a lot of media. This is in Lebanon, actually. My team was so happy that they were on TV in Lebanon. So, and this was the first paper we published on feasibility and proof of principle, where we looked and we tried to come up with protocols, and and it was a learning curve, and we were trying wires and trying what's the best steps to do to make it. Those are the cases in the first paper, which is a mix of diagnostic angiograms and carotid stents. Then later on, this we published in Journal of Neurosurgery. We did a comparison of manual and robotic assisted stenting, because we wanted to make sure that we're not using more contrast or using more radiation. So we compared both, and there was the procedural time was a little bit longer, but this didn't translate into any increased fluoroscopy time or any increased radiation exposure or any increased contrast. As you know, it takes a little bit longer because you're prepping the robot, and it's also a learning curve, but the learning curve isn't so bad, and I think you need to do 5 to 10 to feel comfortable with it. Our fellows are really excited because we're training the next generation of neurointerventionists on the robot. This is our fellow that tweeted. She was happy that she did a robotic stent. In the US, all we can do is peripheral, which is carotid enters into this category. But as you know, Vitor in Canada, they were able to do coiling and stent-assisted coiling, and he was able to really land the stent in very accurately, especially in tortuous vessel. This is the paper that he's published, where he showed all those stent-assisted coiling that he's done with the robot. And we were working on the robot. We were happy with it until this little creature invaded our world and everything changed. And then we found that there is potential another use of the robot, but not in its version now, which is trying to have social distancing and staying outside the room if the patient has COVID. And then it's exactly how the FDA gave, emergency use authorization for some of the medications for COVID. Same thing, I think. Endovascular robotics may be the answer for distancing in protecting the team. In the US right now, as I said, we can do only carotid stents, and maybe we need some expedited approval to be able to do more. What are the advantages? The precision and the sub-millimeter movements. As I showed you, there's those buttons that are on the screen where you can really be very precise, and it would torque 1-to-1, and it's different than if we're doing it manually. When a robot holds a wire, the wire is like fixed; it doesn't move. And whoever is the endovascular from the audience here know that in general, it's a balance between holding a wire, advancing microcatheter. But here, once the wire is pinched, it's pinched, and then it is actually very precise. Accessibility to care, well, this is in case we are able to do remotely. At this point, we are not. Avoiding radiation exposure and ergonomy. As you know, the lead carries weight on the spine. And then avoiding contacts during pandemics. What are the limitations for remote use? Well, the bandwidth of the internet and the lag, because there's going to be a lag with that. But as you know, in India, they were able to do it. And now with the 5G, maybe this wouldn't be a problem. And the major issue is you're going to tell me, what if a complication happens? This is a very important point. If there's any extravasation here, we're not talking about remote intervention for elective cases. We're not talking about go remotely and treat an aneurysm. We're talking about here what is the other option, right? If a patient with an acute stroke gets to a remote hospital, where if the patient's gonna make it to the hub hospital, it's gonna be too late to do a mechanical thrombectomy. So between the option of not getting any stroke treatment or getting a stroke treatment where the patient is, maybe the benefit outweighs the risks in this case. You're going to have an operator on site, someone who knows how to put a sheath. Now, this is also tricky, and it's a nuance, because if you're going to have someone there, well, maybe you can train this guy to be able to do the procedure. Also, as you know, in some places, cardiologists are doing mechanical thrombectomies. The medico-legal aspect of it is still, unknown. Who's going to be responsible? The guy who's in 30 miles away manipulating the robot, or the doctor who talked to the family and who put the sheath in and is there. FDA limitation, FDA at this point didn't clear it for any remote. And then we talk about haptic feedback, and this is important. This is mainly if we're gonna do intracranial. As you know, for peripheral, it's not very important. Haptic feedback is important, but if you think about it, we all train fellows, and we are teaching hospitals, and we trained our eyes to look and see if something is going wrong. You see, for example, the coil, that there is extra pressure or there's friction. So we rely on the vision more than what we think. And we all know how when we're looking, suddenly we can push the fellow aside and say, oh, let me take over and take it. So haptic feedback is important, but the visual is also much important. So I think as a conclusion, this is an easy setup. It's user-friendly, and it has a quick learning curve. But I can say that it's not ready for prime time yet. So we are excited about the technology for the possible future application. We want to be on board to be able in the future to do much more things. And as I said, the potential future would be to minimize any geographical disparity in stroke care. We need to be able to overcome the limitations I talked about. And then, it's a tool of distancing, but, hopefully the next pandemic will be in 100 years, like the initial pandemic was 100 years ago, and we won't have to worry about this anymore. So control technology and don't let technology control you. Thank you.
That's great. That's great, Pascal. Thank you. Yes, very exciting indeed. Very exciting indeed. Okay. So next I'll invite our current fellow, Nick, who would like to show the panel a case, get their input, and after that we'll get into the discussion of the various talks from the audience and between each other. Nick, you want to upload your slides?
Hey, Dr. Marcos, can you see my screen?
Yes.
Can you hear me okay too?
Yes.
My name's Nicholas Kahn. I'm the current fellow working with Dr. Morkos with the skull base and cerebrovascular team this year. And I know I, for one, learned something from each of the talks today. I'd like to share one case with you here that we chose because it can be managed several different ways and to get the panel of experts' opinion on it. So we'll just go through that. So this is a 25-year-old female who came to us several months ago with headaches, and she was referred to us from an outside hospital with a 14-millimeter left incidentally discovered fusiform aneurysm. She has no other relevant past medical or neurological history. Here's a formal angiogram, and it should play. Left carotid injection showing the fusiform aneurysm, the magnified oblique view, and a 3D rotational angiogram. I'll let it play for just a second so everybody can see it. And here's a magnified oblique showing the frontal M2 branch coming out of the dome, as well as the temporal M2 coming out of the base. So in summary, this is a 25-year-old female who has an incidentally discovered left fusiform MCA aneurysm with a frontal M2 branch coming out of the dome. And we'll just stop there before going any further and get the panel of experts' opinion on how they might manage this patient.
Giuseppe, what would you tell this young woman we know about the natural history of these things?
Well, I mean, we don't, of course, this is an unusual aneurysm for a variety of reasons. We don't know the natural history. I think that, first of all, she's 25 and the aneurysm is a dysplastic aneurysm. This is not the typical MCA bifurcation aneurysm. It's what I classify as an M2 aneurysm. So because of her young age, the size and the appearance of the aneurysm, I think it's reasonable to consider treatment. I think the most important consideration when we consider treatment is if we think about the young age, the etiology of the aneurysm, and the fact that this is not a typical bifurcation, but it's a dysplastic M2 aneurysm, to try, clip reconstruction here will not work because the risk of recurrence is very, very high. And therefore, either you do consider some reconstructive endovascular treatment with flow diversion, which in this case would probably be my first choice, or you have to do bypass and trapping of that aneurysm. Otherwise, any other surgical strategy is more likely to fail over time. The reason for considering flow diversion in this case is that we have done a few. It's primarily because I think if that doesn't work, then I have the surgical option later on, and of course it's less invasive.
Any specific flow diverters you'd use or anything? There are so many, I guess, now.
Yeah, well, we still have, most experience with the pipeline, and that's just because I would feel much more comfortable knowing how the device would behave and respond, that I would go with that choice.
Pascal?
So in this case, I have a hard time jailing the M2 with a flow diverter from personal experience. I've treated big fusiform MCA aneurysms with flow diversion, but when the MCA aneurysm is at the M1, and in those cases, actually, you can have good results. In this case, where if I'm going to use a flow diversion, I'm going to definitely have to jail the inferior branch, the temporal branch. I'm worried about that. I think in this case, open surgery would be. I would like to see the distal MCA branches to see at an area if they are really close together. A side-to-side bypass would be an option, and then clipping proximally at the aneurysm, and then clipping the aneurysm as a saccular one would be an option. I think reconstructing it with clips, I think I would go with possibly doing that, but I don't think it's gonna work well because it's a 360 disease of the vessel. She's so young and it's all around diseased, and I think she has some kind of collagen disease, and we need to be radical with this patient.
David?
I saw a case like this where I thought I knew what I was going to do, and the interventional hybrid neurosurgeon showed the case. It was actually a ruptured case that he was convinced there was a small Acom that bled, not knowing which aneurysm bled, and was going to treat the Acom with coiling. And then he starts sizing a pipe for this aneurysm. I told him, I said, you know, the device you need for that big middle cerebral aneurysm is a helicopter. And I meant it. I think that there's absolutely no reason to flow divert this case. There's no, in a good hands of an expert revascularization surgeon, I think this is a relatively straightforward problem in all honesty. I think probably you could get away with an STA of the upper division and then just deconstruct the lower division with a clip. That's very possible. I think you have to be prepared for all eventualities. I think I would probably go with that. And then if as long as there was a decent STA, if I couldn't get away with preserving the inferior division with a clip, you can side to side the two M2s after you bypass the first one. A lot of this depends on the local anatomy once you get in there. I don't see another branch proximal beyond the temporal branch up to the bifurcation. I have been fooled where you find, a small branch that you want to preserve, but, you have to be prepared for this. The only trouble with the STA as your donor here is you are not able to basically clip the base of this and preserve the inferior division. You're left with revascularizing the MCA with only an STA. And so then you have to, then what is your fallback then if it's a small STA? So if the STA wasn't robust, or at least I didn't have a good MCA stump, I'd probably default to a IMAX and have that available if the MCA wasn't good enough. But I think the key is just having all the options and determining, what the best course of action is once you get there.
Great. Paul, number one, would you treat? What would you tell the patient? And number two, how?
I think I would treat Jacques, although, I'd like to see the STA, as David said. And I really have no experience with endovascular techniques with this, and think I side with David. It looks as though you could reconstruct preserving the temporal M2 with a clip proximal to the aneurysm, and then reimplant or bypass to the frontal division, or do some other sort of reconstruction. And if you had Nova, you could try and see what kind of flow is going through the STA and those M2s in advance, and see if you might need a larger graft. But yeah, I think at age 25, this is going to get worse over time.
Okay.
The trouble with Nova pre-op, you can't the STA flow.
It's
it's
too
just
small.
a high resistance. It's a messel. I actually, going back to whether to treat it or not, I would treat it. I think I've had a tough time with watching these grow, or even partial portion of this being left over that regrew after a bypass. I think these are, especially if this was 65, I'd watch it and see if it grew. 25-year-old, I think you're taking an awful lot of risk.
Now, having said that, as a side note, I saw a patient when he was a medical student. He's now an associate professor of a certain subspecialty with a much more complicated, actually, aneurysm that I've done nothing to. Very dysplastic, much more difficult than this. Has not changed at all in 19 years. So I agree, we don't know the natural history of those very well, but clearly can be very benign too.
Attention, medical alert, code blue, Francis, main floor by the main.
I don't think you're wrong to
Yeah.
image this in in 6 months or a year with your CT, as long as you have a good baseline. I don't think it's an emergency.
Yeah.
So, depending on the patient, I think that's very reasonable to follow it.
Yeah. It's also left side, and it's the frontal branch. So
Nick, back to you, Nick.
Yes, sir. Well, press on. So this is the external shot showing the STA measuring about 1 millimeter, as well as the IMAX below. And this is kind of
hold on, Nick. No, go back,
Okay.
Nick. Let's ask their opinion. So any of you, I just for the speed, any of you would look at an angiogram like this and say, this is, what do you do with this caliber that you're looking at? Is this a no-go STA? This is hopeless. We should think of IMAX, saphenous vein, radial artery. Any of you?
For this case, I would probably dissect both branches. It's a decent size proximal STA, the STA stump. It's basically almost 2/3 the size of the IMAX here. It's like the STA stump will be adequate, I would argue, in general here. And you could either do a double barrel, or you could do a single graft to the upper division, trap it, and try to clip the inferior division. You have all the options here. And then you could always have prep the leg or the arm if you didn't have enough. And then I would do a cut flow intraoperatively, measure the flows of both M2s to know what flow I was trying to preserve, and plan, at the time of the treatment. That's basically how I would approach this.
Okay, go ahead, Nick.
And this next slide should show, I think, almost just what was said here. So A was one thought that we had, which was a side-to-side bypass with trapping of the aneurysm. B was a basically re-implantation of the frontal branch, and C was a double barrel, and D was a single barrel with trapping of the aneurysm. And we were prepared for these. We were kind of going to decide what the anatomy was when we got there. We prepped the arm as well as the neck just in case, and we did a terional incision that lined up over the STA, and we'll play some of the operative footage here. And I'll jump through a little bit of this. This is just harvesting the superficial temporal artery.
I love the using the Colorado for that. That's nice.
Yes, sir.
Japanese use bipolars. They'll strip with the bipolar. I've seen the guys
That's
do
right.
that. I still rely on the Colorado for that. I like that.
The David technique.
Yeah, David technique. Carlos David technique.
Correct. That's right.
This is just a little bit of the sylvian fissure splitting. We can see the aneurysm in view. We just caught a glimpse of the frontal M2 branch, and we'll just fast forward. There was a small vein that was crossing the fissure that we had to mobilize. A little bit more of this sylvian fissure split, and then you can see the temporal M2 coming now, and the aneurysm is in view here. We'll fast forward a little bit. And then at this point, trying to decide,
Nick, sorry, Nick, for the younger audience, freeze it and just explain. Oh, perfect. Here you go.
Yep. So here we can see the aneurysm, which is highlighted in red. The temporal M2 division, which is going to be inferior, is in blue, and the frontal M2 division is above it. And we're pushing them together to see if a side-to-side bypass would be possible, or would the ergonomics and the geometry of this be better for a STA bypass. I want to start the video again here. We did measure the cut flow, and I think it will come up in just a second, of the STA, which was 80 cc's per minute. One of the things I've learned with Dr. Morkos this year, he does not allow me to say an STA is a low flow bypass because it can be so variable. So that's one thing I've learned. But this is our flow measure.
Homage to Fadi Charbel, of course.
He's the Fadi Charbel school of bypass nomenclature.
Right.
This is our flow measurement in the temporal M2, which was 30 cc's a minute. And then in the frontal, which was 20, for a total of 50 in the MCA distribution. And this is removing all the adventitia off the STA here. And I'll jump through a little bit. Oh, there we go. And this is the cut flow that we measured once all the adventitia was removed. I made a little tunnel through the temporalis muscle in order to make sure it wasn't constricted. We ultimately decided to do a single barrel to only place one of the divisions at risk. And then also the aneurysm was quite large, and getting under it and clipping it, we thought that we would have to divide the frontal M2 division in order to raise it up and make it basically a saccular aneurysm. So this is what we did. This is using the apex knife for the arteriotomy and a microvax in place. And we'll move forward through some of the suturing of this.
Scanlon, Jacques?
Yes, you know, I got used to them, and I'm sure there are even better instruments, but once you get that feedback, you know.
I hear you. Yeah, I don't disagree.
Yeah.
My problem, I mean, the Charmonts are great. The tips of the needle holder and the tying forces are really thin, you know,
Yes.
and it's almost, that's just, but I've used Scanlon for years. I just recently switched.
Yeah.
Jacques, I thought you like to do running.
I mix it up, you know. Sometimes I do running on one wall. Sometimes I do interrupted to teach my very talented fellows and residents, you know. No, running usually, yes. Okay, yeah, you can speed it up a little, Nick.
Yep. Here's the ICG just showing the bypass in place. And then here we're going to divide. We'll remeasure the flow, which shows that it's adequately perfusing the frontal branch. After that, we're going to
I'm sorry,
divide.
notice 28, which almost exactly matches the 30. It's remarkable how the brain will know more than we, the surgeons, will know what is needed. And again, demand controls supply. Sorry, go ahead, Nick.
And here we've divided the frontal branch, and we're basically making this a saccular aneurysm. And here we'll, in just a moment, temporary clips in present on M1 now. And we're going to permanent clip here with a stacked permanent clip configuration.
Yeah, I think the main reason to show this case is really the advantage of quantitative flow measurements, and how also looking at an angiogram does not tell you that an STA is hopeless. This was 80 cc per minute. Remarkable what happens when you free it up from the skin. And of course, intra-op flow measurements really guide the strategy that you can use. And again, for the younger audience, again, I encourage them. I have absolutely no financial interest in the flow probes or anything like that, but this makes you think scientifically about these cases and quantitatively.
That patient have a trigeminal artery also.
That's right. Interesting. Yeah. And here we go. Yeah, we can, that's
Okay.
it, Nick, I think. Did you have other slides or?
No, that's it.
No, that was it. Comments from the panelists? Any discussion before we start discussing your talks?
The only thing I would say is go ahead, Paul.
I was going to say, we didn't talk about the Charbel, the newer Charbel bypass, using a single vessel to bypass two divisions of the MCA, but that wouldn't have been appropriate.
In press is my series of what I call the 1D2R, and we're publishing. Nick is first author, 21 cases accepted by Journal of Neurosurgery. Look out for it because it actually introduces new concepts of measurement. Fadi introduces the CFI, cut flow index. Mm-hmm. We're introducing I'll let you read it later and see what it is. Sarah and Sassy. That's what you're going to be reading in the paper. Sarah and Sassy, I'll let you know what they measure, but it'll be fun.
The only thing I would say is
I love it, yeah.
But that's a great case, number one. Number two is you don't give anything up. I mean, you if you're going to go ahead and do this, don't just be committed to one option. You know, you dissect out both branches, have both available. Because you never know what you're going to encounter, and sometimes it's hard to predict. And if you don't have all the options, whether it's side to side, double barrel, clip deconstruction, you have to, because you'll have another case like that, and for whatever reason you can't. You have to reimplant that branch because there's some athero there. There's a branch coming out of it you didn't expect. So you have to have these in your armamentarium and learn how to do side to side is a great technique to learn. It's a great bailout technique sometimes when you don't have, say, a good donor or something like that. So that's a great case. I think you obviously thought it through. You had all the options. That's why you had a good outcome.
Great. Let me pick. There aren't tons of questions. Let me just start. Oh, we have here a message from, I don't know if you know Dr. Clara Raquel Epstein. I know her very well. She's, I guess, listening. She wanted to make comments about Dr. Roten having discussed the importance of posture and upper body strength for optimal surgical technique. And you guys all remember Roten doing the push-ups. Lifelong neurosurgeon optimization for longevity in both one's career and optimizing the duration of longer cases, including improving personal protection with better ergonomics using exoscope and neuroendovascular robotic assisted surgery is a game changer. As we know, iatrogenic disease, cataracts, thyroid CA, potential sterilization and progressive kyphosis, despite appropriate gear over a lifelong, are cumulative risk. It's very true. Thank you, Clara, for being with us. A question from, oh, that's kind of a general question, from one of a medical student listening to us. I'll ask Paul, as a current chair of a program. Paul, what do you think should great neurosurgical residency programs have? What should medical students interested in pursuing a career in neurosurgery look out for? Maybe I'll stop here in the question. What advice do you have for medical students looking for great programs in neurosurgery?
I would say you want to look at a program that's very comprehensive, that has, you know, technical expertise in the vast majority of neurosurgical disciplines. You know, expert microsurgeons, skull-based surgeons, endovascular surgeons, spinal neurosurgeons, functional neurosurgery. You want to try and pick a place that has excellence in many, if not all, of those divisions, rather than concentrating on one in particular. And you want to look for a that is, if you want to, you know, be at the top of your game and be experienced and technically, you know, competent at the vast majority of neurosurgical cases. Obviously, you want a place with a good feng shui, as David mentioned, a good crew of residents and collegial faculty as well.
Anybody else want to give an advice for our medical student?
I would say one word. I would look for a place where they would advertise for a disease, not for a tool.
That's very true, Pascal. You know, and you just reminded me how, for example, the cardiothoracic surgeons disappeared while the peripheral vascular surgeons flourished, because the first ones never believed in endovascular. The second ones embraced it. That's why there are people like you know, in neurosurgery and others. You're right. You have to be a disease specialist, not a technique specialist.
I have a little bit of a contrarian view on this.
Yeah.
You know, and I think it reminds me of my kids, you know, and where should I go to college? Look, there are very few bad neurosurgery programs. I mean, that's why we have the RC. They're all reviewed. You know, I mean, you're not going to go. When the purpose of, you have to think, what's the purpose of my residency? The purpose of the residency is to do straightforward things done well. You're not going to come out of your residency being a Jacques Morcos or a Pascal or a Paul. You're just not. You may think you can, but you can't. It's a lifelong system of learning. So the most important thing, once you have an accredited program and the geography works for you, and they have the right, and there's a track, I mean, they're probably, you know, that's probably applies to 70% of the programs. You got to have a guy like Jacques or Paul or Pascal in the program, because you need mentors. You need people who are going to fight for you, who are going to go make a phone call, who are going to get you that fellowship, who are going to offer that additional training, who are going to expand on that base training you have during those first 7 years. I mean, I continue to learn every day, you know, and I would, if I polled Jacques, Paul, and Pascal, I would guarantee that none of them are doing the things today that they were doing when they finished their residency, you know, 400 years ago, like these guys. So, you know, we tend to make a big deal out of this as medical students, like, oh, this is the best program, that's the best program. What's best for some list is not necessarily the best for you. Don't listen to anybody else. Keep your eyes on the boat. Focus on what's best for you. Maybe there's a family issue. Maybe there's a geography issue. Maybe, you know, whatever. But make sure wherever you go that they have a track record of mentorship, support, collegiality, ethics, that there are mentors. It's diverse, that you feel comfortable. You know, those all matter, because you'll learn to operate if you put your time in, and then you're going to do that fellowship and expand your knowledge set over time. So don't put too much pressure on to find the best place. It's all up to you ultimately. And some of the best programs turn out some bad surgeons, and some of the best turn out some of the worst. So rest assured, everything's you know, up to you.
Very, very wise, David. You know, that's so true in many ways. Giuseppe, I'll ask you this as a question from the audience, since you were the only one excited about endovascular treatment. Is why, on that last case, is why flow diverter an option for the last case to ensure patency of the temporal branch?
Well, I mean, you can jail the branch, and you can the branch can potentially be jeopardized if there is if the patient has a good leptomeningeal collaterals. You, by jailing that branch, covering the branch with the flow diverter, you might encourage occlusion of that branch that, if adequately modulated, usually tends to be asymptomatic, and it's related to the presence of decent collateral. So the way you do that, once you jail that branch, you watch very carefully to your angiograms, and usually these patients over the first 24, 48 hours are maintained on Agrastat, or you can manage that with pharmacological manipulation. So there are ways of assure that that branch stays open. And often, if it doesn't stay open, as we have learned in many patients with acute ischemic stroke, is that there are leptomeningeal collaterals that and that's the reason why that branch might close. Now, I don't necessarily agree. I mean, there are options, and there are valid options, but I mean, we have treated a few of these M2 aneurysms with flow diversion, and we have had good results. But as I said, the pharmacological peri-procedural strategy, it has to be, very important.
Jack, there's something in the question. They said, why flow diversion? Like, why this? I mean, this is.
Oh,
not,
you mean a why or?
Oh, yes, that's what I mean. Yes, the Y shape.
Oh, sorry, I missed. I missed completely. Yeah.
Yeah, because this is not feasible. I don't know. Maybe they meant why stenting, regular stenting. But
I think
why?
that's what, yes.
Yeah, why in a flow diversion cannot be accomplished?
Yeah.
Right.
No, but in that case, it's an M2. You need to somehow reconstruct, either reconstruct that segment or completely trap the aneurysm, exclude the aneurysm, and flow replace.
Paul, a question for you. Have you tried water dissection technique that I think it's fair to say has been popularized by Ernest Nemi in splitting the fissure?
No, I have never never tried that, Jacques. When we were young, Ali came out with the little balloons that he would put in the fissure. Ali Krisht was working with a company, and for a while we tried, taking a small little balloon on the end of a catheter and inflating it to sort of split from the inside out. But I haven't tried the water dissection. I'd be interested to take it.
I like it a lot. It's very nice for tough fissures. It just gives you extra space. And what go ahead. Sorry.
Oh, no. It's also fairly, I found it very useful in acute subarachnoid hemorrhage cases. Once you make a nick, it helps a little bit, dilute that blood that is in the fissure too.
Yeah. I was going to say something. I forgot then what, talking about David saying what you change over time. I mean, I used to dissect the fissures with bipolars and stuff, but actually I use now the Scanlon bypass instruments for tough fissures to start it. And it's very good for beginners, particularly who are very worried about going subpial and stuff. Get some going. Dr. Uday Gupta asking about, can we go retractorless by suction dissection? I'm not sure. This is probably for you, Paul, but I'm not sure exactly what he means. Suction dissection. I
didn't see that.
Well, Carolina, who was here earlier,
okay.
But she must have pushed it on the dismissed port.
Well, I think maybe he's talking about using the dynamic retraction, just using the suction retraction,
which you talked about.
Yes.
David, exoscope from Dr. Oriella Rustemi. Exoscope does not have direct optic. I think it's meant it's not looking directly. Does this affect the time, your reaction time? For example, do the times of your anastomosis time differ between exoscope and microscope?
No, not at all. In fact, when I used to do a back wall, I put the exoscope way away from me. So I'm getting this angle where I'm looking on the back wall with the exoscope and I'm operating like this. I'm not like going like this. So my body position is neutral. The exoscope is across from me, and your brain and your wrists are able to, make up for these angles. So it's like endoscopic surgery. It's the same thing. You're able to take these new angles with your wrists, not your neck. And so the exoscope takes the angle, and it's just a totally different experience. You can see things you wouldn't have seen. You can put yourself in positions. It's not every case, but if anything, it makes the anastomosis faster. There's also a question was missed here about navigation. It says, very good webinar. Regarding the presentation of the Orbi, I also think it's a very nice tool, but it's not compatible with neuronavigation. Parentheses, there's no image injection as with the Kinevo or Leica. This seems to be a problem, needs to be addressed. Not true. I have the Leica. I had integration. The problem with microscopic integration, first of all, it's $50,000, number one. And you can only put on one microscope. If you want to integrate all your scopes, each one costs $50K. They have to come in and put that silly array on every microscope. And about half the time when you go to use it, the scope itself is blocking the patient array. It's in the way, or the camera doesn't see it, because you really need, the camera needs to see 2 points. It needs to see the microscope and the array. And half the time, one blocks the other. The other problem is you can't really operate while you're navigating, because you can only look in one eyepiece, or you're looking around the outside of the microscope to see the screen, which just slows you down. With the exoscope, for $0 down, 90% of the time, at least the Olympus doesn't block anything. It's low profile. Picture in a picture, you literally have the B plane, which is your navigational image, in your operative view, and you're just going back and forth, because your assistant or you can put a pointer in. I often have my assistant put the pointer in while I'm operating, and then I'm looking up at the PIP and then going back to surgery. So the integration for an exoscope without paying a single dollar blows away the microscopic integration by far. Now, where it fails is some of the pre-op, where you're getting a trajectory, but then just use your pointer and then just aim the exoscope in the same orientation as the pointer. It's a little bit of a mashup, but
David?
Yeah.
I have a question for you about the learning curve. So it's been 6 months. We have the Synaptive exoscope. And at this point, from aneurysm standpoint, I tried it in multiple. I'm using it only for MCA aneurysm. I feel that Acom and PCOM, I'm struggling using it. MCA, I'm using it comfortably. Carotid and endarterectomies, I'm using it comfortably. Any advice, and how was your learning curve? And like Acom and PCOM, I'm starting with it, but at the end, I'm just moving it and bringing the microscope.
But why are you moving? Share with us why you.
Yeah. So first of all, they want me to use the 3D all the time. I feel I'm dizzy with the 3D. I'm having sometimes like double vision with the 3D. They teach you the technique to cross your eyes, right, at the beginning to be able to see 3D. And once you remove the 3D and you are a little bit deep toward the skull base, I feel that I don't have depth perception very well. That's why the more superficial aneurysm like MCA, I feel more comfortable. What do you think, Dave? I don't know.
Look, there are about 10% of people have some sort of parallax with the 3D. I wouldn't use the exoscope if you're one of those people. There's no reason to. I mean, you should never be operating not in 3D. Why would you subject yourself to an inferior optics just to use this thing? It just doesn't make any sense. I mean, John Bookvar, for example, gets parallax. He has trouble. His brain, whatever it is, struggles with the exoscope. So I wouldn't use it at all. I mean, there's no reason to use a 2D image for an aneurysm, especially an aneurysm. I personally have used all three. I'm biased to the Olympus exoscope. I think that the optics, the zoom, and the quality image is superior. And the Synaptive is really a navigational device. So if you need navigation, or you're operating a deep cavernoma, or something really deep where you need trajectory constantly and you need the scope to move in a trajectory, if that's your goal, the Synaptive is a superior instrument. Personally, I think the navigation component is a little bit more than most cases you need. You don't need navigation for spine or aneurysms or the vast majority of surgery. And the synaptive optics, I don't think are up to speed yet. They're working on them. You know, I know the company's hard at work, but you can't zoom past 50% without optical 3D in the synaptive. So the image gets morselized. It just, I would argue that I would just use the microscope for that. And
now, how long did it take you on the transition period from microscope?
Very little time.
How many cases?
I never went back. I mean, I just started on the skin, and I just committed to it. You know, I have not dropped a microscope in. I have not given up on it with the Olympus. It's not, you know, it took me 4 cases before I, you know, was, and I was motivated to do it because I really wanted to. You have to really want to do it, and you have, if you're a mouthpiece guy, you're just not gonna have that motivation. But I do think the synaptive, and even the synaptive is a robot. It's you know, it's a little bit more cumbersome and a little bit, there's a lot of engineering there. It's a terrific device. I mean, you know, navigationally, it's incredible. I just, you know, if it's just as a workhorse imaging device, the Orbi is exceptional, and the images are breathtaking. I mean, it's profoundly different for me to watch. I just, when I operate with a microscope, I feel claustrophobic, and just got to make commitment to it.
David, when I operate with a microscope, I'm in the flow zone from that book that you gave me. I am in my zone. I love it. I guess that's the difference.
It's funny you say that. Part of the problem with the verbal movement, with the audio, like speech commands, is exactly that. I don't want to talk. Once you're like down deep and you're on, I don't want to say, you know, do something. You just,
hey Vimo, right?
Yeah, hey Vimo, you know, you know, you just don't want to do that. And it's, so I use the gear shift. You know, you get XY with a gear shift for all the exoscopes, you know, and these other movements, you know, I just can't, I struggle with that actually.
Pascal, Dr. Nikolai Melita wants to ask you, do you see a potential for AI to support the advancement of the endovascular robot?
Yeah, so this would be, if you want to talk really robotic in endovascular and exciting stuff, is to go and draw an X, your target, and then to do your angiogram and incorporate it and say, I'm going from radial to Acom, and you press a button. And so absolutely there is room for that. This would be really robotic.
You know, I was going to ask you before you put up your slide of disadvantages about the haptic feedback. I mean, you know, when Ajay Waklu used to work with me many years ago, I mean, I thought this is what made a supreme endovascular person, that touch, the feedback. Are you minimizing that disadvantage, or
I am minimizing it in cases of carotid stents and mechanical thrombectomy. I'm not minimizing it in cases of aneurysms. I think in cases of aneurysm coiling, it is important, but it's not as important as people think, but it is important. But for mechanical thrombectomies, not as important as aneurysms.
Gentlemen and ladies, and it's 7:29. Unless somebody has a burning issue, I really thank you for staying an extra half an hour. Very popular show as expected. Anybody has any last minute question or comment or anything? Okay.
Thank you, Jacques.
This is always fun. Thank you all. Thank you to the audience for sticking with us. We reached
introductory music too, Jacques. That's a nice touch.
See you next month.
Good night.
Bye-bye.
Thanks, everybody.
Thanks.